Good morning, everyone, and welcome to the American Enterprise Institute for our event this morning. I'm Tom Miller, as I like to say, Chief Entertainment Critic for Health Policy at AEI and occasional health policy scholar. So what we're talking about today is, could cashing out of Medicaid and Medicare coverage actually lower healthcare costs and improve its quality? In other words, the shorter version of this is, let's make a deal. Now, you may remember, you have to go back, but I always go back in time. Let's Make a Deal, one of the early game shows. Well, all health policy, let's be serious about it, is a game show. Some win, some lose. But the Let's Make a Deal concept, which started in the early 1960s, Monty Hall was the host of it, one of the early Canadian-American pioneers in game shows, followed later by Alex Trebek and others. It was well, we'll explain how it worked in just a minute, but what we're doing today is we're combining Let's Make a Deal with Let's Make a Really New Deal. If you kind of crossbred FDR, with CRISPR technology or whatever, and you got kind of a different approach to major entitlements and a new project. So let's talk about the original Let's Make a Deal show. That was basically where you would have the contestants who wanted to get the attention to get on the show. They had to line up with various wacky costumes, such as, you know, our three discussants today, trying to get attention for the health policy universe. And you get chosen for the show based upon how you showed up. And the idea of Let's Make a Deal was you started off with a deal, but you could always do better, or at least you could imagine you could do better, or perhaps you could do much worse. And the standard setup was to have door number one, which is where you would get your initial prize. Then there'd be the other choice to upgrade or get something given to door number two, door number three. Sometimes they'd have what's behind the curtain. Sometimes they'd be holding in this box. The idea was you could take a risk and come out better. And in some ways, that's what we're talking about in today's program, which is if you took a few more risks with what you do, maybe you could do better. Let's make a better deal in health policy. So that's concept. Now, the problem is that if you really did badly, you'd get what was called a zonk, which was basically worthless and go home and have a lovely parting gift. So that's our premise for today. What we have on today's program, David Hyman, who I'll introduce in just a moment. He needs no introduction, but insists upon one anyway, has written two provocative papers, not yet hitting his main realm, the law review and law journals. David is one of the most frequently published, frequently cited health policy. That's not even counting his own self-citations. He's very productive and pushes the envelope, and he's been doing that for a number of years in this particular realm of moving toward a more cash-based health policy structure. So the two papers that we have, which you didn't have to read through, but I'm obligated by my job to do so. One is called Leveraging the Medicaid Expansion, came out last fall. Another is coming out soon on leveraging Medicare, how to deliver affordable, high-quality health care. Now, it's somewhat of a case of, in case of emergency, break glass to do this, but I'm picking up a theme here, which is when the same title basically, each title has leverage in it. Perhaps that's what we're really trying to do. Use current problems or difficulties and leverage them. It reminds me of a TNT show from about the late 2000s into about 2014, I think. Ran for about 5 years on TNT called Leverage, where they had a gang or a band of 5 highly skilled operatives who did various type of misdeeds, but they were like Robin Hoods. They were trying to settle the score with corporate or governmental evildoers who had taken advantage of poor citizens. And so in some ways, there's an analogy to that in terms of what we're leveraging today in this regard. David does some other leveraging in terms of he's leveraging the imminent, which is always going to happen in 5 years from now, Medicare financial disaster, but at some point it might arrive. And so in light of the financial difficulties there, what could we do differently about Medicare? And he also leverages a book that came out last year, We've Got You Covered, which talked about how to deal with the financial insecurity of lack of health care coverage by having a more basic type of coverage. So those are the building blocks on that front. But at the core of what David Hyman is proposing today is the idea that cash is king. This is a concept that went back actually decades ago in economics. That works better in a depression, actually, than in an inflationary environment. But if you have cash in your pocket, you're the customer. You can begin to have more leverage and control over what you're getting, and you're the person you're going to pay attention to. Cash transactions are more transparent in terms of their prices and costs, and also, hopefully, the quality produced while you're giving away that money. This has been done in marketing terms in other ways before. Some of you in the D.C. area, going back a couple of decades, might remember the slogan that an educated consumer is our best customer. Cy and Marcy Sims, a little bit of a stripped-down retail approach, nevertheless delivered value at the time. That's from the mid-'80s. Now, even they ran into the difficulties of the economy and ultimately had to close up shop. It was very successful in that regard for a while. So this has been tried in other retail sectors, not as prominent in healthcare. A different way to think about this, I'm just trying to help out on the marketing for this, David, is to think of this as a way to deal with another welfare program that we've had problems with, not AFDC, which is the one that was phased out, but aid to providers, or aid to patients with dependent providers. That's pretty much writ large throughout the healthcare system. No cross-promotional plugs from a particular diet truck, but this would be a way to suddenly put that into their system so they weren't as hungry for things and perhaps would cut back on their appetites and would have to compete more vigorously to attract customers with lower prices, higher quality, or at least its overall value. Now, I did not introduce David, which I'm about to do right now. Aside from saying he produces a lot of work of high quality, he is a he wears many hats, let's put it that way. Today he's wearing an AEI visor for us, but he's also an adjunct scholar at AEI, adjunct scholar at Cato, and the more of the full-time job among many others is Scott Ginsberg, professor of health law and politics at Georgetown University Law Center. He's published a number of books before, starting with Medicare Meets Mephistopheles. Mephistopheles didn't come out too well for that one, neither did Medicare. Also Overcharged a few years ago, which we'll talk about to some extent, and also work in government, A Dose of Competition, when he was special counsel at the FTC. This is kind of like, it's like trying to put a normal brain into the healthcare abnormal, monstrous system. In other words, it's sort of like a Frankenstein moment. And as Gene Wilder in Young Frankenstein exclaimed when he did it, even though it seemed odd, this could work. So David's going to explain how this could work after setting the stage. David Hyman, thank you.
Thanks, Tom, and thank you all for coming. I don't think I can match Gene Wilder. This is a paper with Charlie Silver, who couldn't be with us, my pretty regular co-author at the University of Texas. And the title that I gave it harkens back, obviously, to some of the points Tom made, and the sort of broader theme of these two articles. It actually started as one article on Medicaid and thinking about the problem of how we might make a Medicaid expansion more appealing to the states that had not to that point opted in by crafting the program somewhat differently than has traditionally been the case. And then we subsequently realized that some of the ideas we were developing, not all of them, had promise for moving Medicare reform forward in a direction different than had traditionally been the case. And so we now have these two articles with lots of footnotes that the students are busily fixing up. But I'm happy to share them with anybody in the audience who's interested in them. One of them is posted on ssrn.com already and can be downloaded for free, and the other should be there within a week. So let me just start by getting you to lower your expectations about these papers, me, this talk. This is Greg Scanlon, who's known to, I suspect, some of the people in the room, a longtime health policy analyst working in Washington on the conservative side of the divide. And he somewhat memorably wrote about a prior article in 2007 that it was, quote, a surprisingly readable paper for a professor of law. So you should calibrate your expectations about things that law professors will write accordingly. I also think you might want to lower your expectations about this idea. The history of health reform in this country is we see fads and trends and brilliant ideas that come and go. Sometimes they get deployed, sometimes they get ignored. This is actually the graphic that AEI sent out about this talk. The piggy bank, I busted Tom's chops a little bit about why he chose it, and he said, I thought you picked it. But I think
Did not choose it.
you did not choose it. But you know, the reality is healthcare is big business. It's also a very important issue. Healthcare is personal to people in a way that lots of government policies are not. It's very important that we try and get it right, and there are lots of aspects of our current healthcare system that fall well short of even a pretty low, you know, C- grade for the performance of our system. Now, that's not to say that all aspects of the system are awful. At its best, American healthcare is truly exceptional. After most of a career spent studying the healthcare system, I got to see it from the other side as a trauma patient, and it's pretty exceptional when it's performing well. Let's not talk about the billing that followed. But nonetheless, I think you should not assume that there are not going to be hiccups, problems, difficulties, things that we haven't thought about, unintended consequences. And by way of analogy, there's a movie from a couple of years ago about the search for the Higgs boson particle called Particle Fever, and there's this wonderful quote from a physicist, theoretical physicist, that the secret to his success lies in jumping from failure to failure with undiminished enthusiasm. There's a lot of that in health policy as well. We jump from one idea to the next, and we tend to focus on the things that have gone wrong, understandably, but there are certainly no shortage of things that are going right. Now, the big three issues in health policy are obviously cost, quality, and access. I used to tell my students that if you could train a chimpanzee to say those words, they could be a health policy analyst as well. But it's nonetheless, and I stopped doing that because they didn't like that. They thought of themselves as significantly more evolved and adding more value, and some of them did. But nonetheless, I think it's a useful framework for thinking about both where we are and the costs and benefits of any proposed reform, whether it's the ones that I'll be talking about today or whatever the latest thing is that comes out of whatever your favorite policy shop is. So let's start with cost. The American healthcare system, we're number one. We're uniquely expensive relative to everybody else. It sort of doesn't matter where you look for that. This is a quote from Mike Levitt that I told Joe I would show today about the perennial topic of Medicare insolvency. Every year, the Medicare trustees issue a report. The only thing that changes is how long it's going to be to insolvency. Sometimes it's 6 years, sometimes it's 12 years. It goes up, it goes down. Secretary Levitt points out in the spring we see the cherry blossoms and hear Medicare warnings. The cherry blossoms go away, but we don't really do much of anything with Medicare unless the date for the expiration of the trust fund drops below some critical level, and then we'll see some tweaks to try and make that number move up the next year. But as Joe has pointed out to me, that's just so they can spend the money on some other things. I think the bigger problem, which the trust fund framework obscures, is the fundamental fiscal imbalances. We promised much more than any plausible tax revenue picture looks like, and you know, the present value of the promises we made it should scare everyone in the room, but because it's not nearly as accessible as, oh, the trust fund is going bankrupt, we tend not to focus on that. We've accrued huge liabilities that I think we don't have any realistic way to pay for. And if you don't like quotes, there's this wonderful long ago cartoon from the Washington Post where Medicare and Social Security falling past a series of windows, and at every stage someone pokes their head out the window and says, our data shows that you will be okay during this segment of your fall. Obviously, the building can't go on indefinitely. There's going to be a reckoning. The only question is when and whether those of us in the room will be around for it. Now, what about quality? And I'm going to obviously start by talking about Medicare because it's an exclusively federal program. It's large, it's popular, but it has some real challenges. Tom already mentioned our book, Overcharge. The unfortunate reality is Medicare buys lots of low-quality care. It buys lots of high-quality care too, but it doesn't create systematic incentives for only purchasing high-quality care. It's mostly a passive payer of bills, whatever comes in. They might argue about the price because they're a price setter, not a price negotiator by and large. Leave aside drugs for the moment. But this is from a Kate Baker and Amitabh Chandra paper, now 20 years old, that points out there's evidence that the more Medicare spends in a given state, the less the quality of the care that's actually being delivered. That should strike you as quite disconcerting, right? That's not typically the way that we think markets ought to be working. And then efficiency, this is always the trump card, pun not intended, for why we should do Medicare for all. There's bragging by its proponents that Medicare, basically has a 1 to 2% overhead that compares exceptionally favorably to the private insurance market. The difficulty is, and Charlie and I have explained this in other pieces, the formula by which we're calculating efficiency is fundamentally flawed, right? All we're doing is looking at the quote overhead and comparing it to total spending. The difficulty is the more money you waste, the more efficient it looks with that formula. The right way to do the calculation is to put the wasted care, the cost of that, in the numerator and subtract it from the denominator. If you do it that way, and I won't bore you with the math, you end up with staggeringly high numbers for Medicare overhead, not staggeringly low numbers, up to 33% and potentially significantly higher. We argue in another paper that the true cost of delivering efficient, high-quality care for Medicare is closer to 40% of its outlays and potentially higher when you take account of everything. So the picture that it's a more efficient program, and in fairness, you should do the same calculus for the private insurers who are buying plenty of not high-quality care as well, but you shouldn't assume that somehow the Medicare program is uniquely efficient when I think our evidence is that it's not. Let me now switch gears and talk about Medicaid. As I said before, this project started with us thinking about the problem that there are 10 states that have decided not to expand Medicaid in response to the original you will expand Medicaid in the Affordable Care Act, that the Supreme Court then said that was unduly coercive and gave states the options. Pretty much immediately, about half of the states opted in, and this is the year-by-year phase-in of Medicaid expansion, just so everybody's on the same page. Medicaid, prior to the Affordable Care Act, included a series of core populations that every state had to include. It's an income-restricted program. It's largely federally funded, but mostly state-administered. There's huge variation state to state. The expansion broadened the populations that would be covered and basically raised the income limits for people that would be included significantly above what they had been before. And the practical significance of that is in certain states, certain large populations of people suddenly qualified for Medicaid, government-funded program with very low or no co-payments, but also very low payments to healthcare providers, which resulted in access problems for the beneficiaries. But in any event, circling back to the opt-in, opt-out problem here, about half of the states opted in immediately, and relatively quickly a bunch more followed. But starting in 2016, we basically stalled for 3 or 4 years the number of states that were willing to opt in. The count For expansion states are the states that opted in. The holdout states are obviously the states that have not done so. And in each year in the far right column, you can see the states that chose to opt in that year. I think the more significant point I want to highlight is we have 10 holdout states, and they're not small states. They're states with a sizable population. And the result is what we viewed when we started this project as a bunch of people who, if the states could be persuaded to opt in, would suddenly get insurance, and that one generally thinks of in health policy circles as a good thing, although there have been some empirical studies of Medicaid that should make you at least a little bit cautious about drawing the conclusion that that improves their health as opposed to their financial well-being. In any event, the geography of the holdout states, for those of you who are wondering what where those 10 states are, you can see right here. A common trope in health policy circles is to look at this map and say the states that didn't opt in are doing it because they're racist, and they're racist because they're part of the old Confederacy. There are some things that I think complicate that. For example, that there are certain states that were never part of the Confederacy that have not opted in, and some states that were part of the Confederacy that have opted in. Our argument in the paper is that there are factors other than racism that we ought to be considering, including the fiscal challenges that these individual states are facing and political constraints within those states that are going to make them reluctant to sign on to the heavily subsidized but nonetheless open-ended commitment that opting into the traditional Medicaid program would mean. And so the let's make a deal metaphor that Tom alluded to earlier, I would have titled the paper that, but we called an earlier paper Let's Make a Deal, so that title was taken. Maybe I should rethink that now, given your comments. The idea behind this was, let's think about ways in which we can revise the offer, the deal that the federal government is offering the states, other than do it our way and we'll subsidize it. Sometimes up to 90%, depending upon how the budgetary dynamics end up working out in the long run. But nonetheless, the core idea here was, rather than saying, do it our way, the proposal for Medicaid was, let's offer the states something that would be more appealing and would address the governance and fiscal challenges they're facing. And the idea that we came up with was for essentially moving from a defined benefit approach to a defined contribution approach, where the states would be able to set the amount of money that they wish to spend, and the federal government would match that in the same way they would match it in other locations. And that's the funding side of it. But the production of healthcare side of this would be, rather than waiting for bills to come in and writing checks at the artificially low rates that the Medicaid programs have traditionally done, we would instead fund HSAs for the beneficiaries to use as they saw fit, by buying catastrophic coverage, by paying for healthcare directly, by spending on the social determinants of health. And that is in some ways consistent with, first of all, how we handle Social Security, the Earned Income Tax Credit, the Child Tax Credit, and health reimbursement accounts in the private market. So the core idea here is to give Medicare, and you'll see another slide, Medicaid beneficiaries money. Instead of paying the providers, we should just put money into HSAs, and the beneficiaries would be in the direct purchasing market suddenly. And because they care about price and quality, direct purchasing creates huge incentives for providers to care about what their patients care about, rather than what the third-party payers / insurers / government payers care about. So we think fraud losses, which are material, are going to start dropping, and other forms of waste are going to take more time to be wrung out of the system. But when people are spending their own money, they're presumably spending it on things that they value and not spending it on things that look like pure waste. So again, it's based on the same model we use for Social Security. We don't by and large, use the federal government, or for that matter, mostly the state government, to provide housing for seniors, to buy food for seniors, leave aside food stamps and housing vouchers for the moment. We instead give them money and let them spend it as they see fit on the things that they value. And the Medicaid version is really very similar: direct purchasing and using money for social determinants of health more broadly than the traditional. We'll pay for things done by doctors and physical therapists and hospitals, but we're not going to pay for anything else. Now, that's been the traditional approach, but what we've seen in the healthcare financing system over time, particularly in Medicaid, has been a expansion of 1115 waivers that allow individual states to start spending money on the social determinants of health for Medicaid beneficiaries. So this is really no different than that. It's just cutting out the middleman and letting the beneficiaries make their own decisions. So the paper spells out that we think there are a bunch of advantages to this approach. A lot of the things that drive people crazy about our current system basically fall out or are no longer necessary. So the government's not going to be in the business of price setting anymore. The challenges of price setting are well known. If it's too high, you overpay. If it's too low, you don't have access. And we've got examples of both of those things in our current systems. There isn't much of any need for prior approval requirements because people are spending their own money. They're not spending the insurance company's money. Administrative headaches, particularly for providers, go down because suddenly they're dealing direct with their customers rather than a faraway insurance company or the federal or state government. Surprise, and I think would be happy to wax poetic about the challenges of suddenly becomes much more automatic. We don't mandate price transparency in retail markets. We mandate or we prohibit fraud, but apart from that, price transparency results because suppliers are trying to sell things and people consider price an important term, so it's in their interest to have it out there. Congress finally gets control of the budget for both Medicare and Medicaid, and the state legislatures get to control, that is, set the maximum amount they're willing to spend on Medicaid rather than it being on autopilot. And the uninsured and underinsured are not left out. They actually benefit from the lower prices because there are many more people in the market who are price-conscious consumers. And as I mentioned in a prior slide, this basically builds on developments that we see in other sectors of both government programs, Social Security, Earned Income Tax Credit, Child Care Tax Credit, but also the dramatic move over the last several decades away from defined benefit retirement pensions and toward defined contribution retirement funds. Now, there are, of course, disadvantages and risks, and there are going to be problems, right? Anytime you're spending $1 trillion on Medicaid, $1 trillion on Medicare, and
We're getting there on Medicaid.
We're getting there on Medicaid, $750 billion on Medicaid. There's no shortage of people who are going to try to misbehave, to try and get more than they're entitled to. We don't think the disadvantage or risk is the lack of precedent. We actually think this is bringing our two largest social welfare programs in line with a third social welfare program, i.e. Social Security. One of the challenges, to be fair, is figuring out how much money per beneficiary you should be putting into these savings accounts, and to what extent should you risk adjust. We think picking things that are easy to observe and hard to game is going to be key, but reasonable people can disagree about what the right formula is for calculating that. It's also, I think, clear and a major source of concern that if you give people money, some of them will use it in ways that those of us who are more risk averse will not like, right? They may spend it on what we view as unnecessary services. They may spend it on social determinants of health that we don't think are good value for the money. and we need to think hard about what we should do. We have some ideas in the paper about how to handle that I'm happy to talk about in the Q&A. But this is not a everything's going to work out fine framework. We need to be tough-minded about the ways in which this system is susceptible to gaming. I think the immediate response to this from providers is going to be to highlight the ways in which they will come out the losers. But what that is an indication of is they're not doing a very good job serving their customers / patients. And it's because they view the federal or state governments as their customers rather than their actual customers. But in fairness, we need to think about, do we want to subsidize safety net institutions, and how do we want to do that? And community health centers, academic health centers, rural locations, all of these are things that I'm sure you will hear about from the commentators as, well, you haven't thought about this and it's going to be a disaster. We have thought about it. We have some ideas about how to do it. But we think net, this is a better strategy, and we should make adjustments for the things that we actually think are important, rather than using the Medicare and Medicaid program as, how did you put it, Tom?
Aid to patients with dependent providers.
Aid to patients with dependent providers. I hadn't thought of that acronym, but it's a good one. And I think the last point that I want to leave you with is this is not going to be perfect. No human institution is. But I think it's implausible that it's going to be worse than what we've done already. So this cartoon is the three little pigs. One of them wants privatized healthcare. One of them wants single payer. And the one in the middle says, I know, let's compromise and build it out of twigs. And that is the unfortunate reality of our current system, is nobody's gotten the all-in outcome they wanted. Instead, we've got a series of compromises. And I think the way to think about the proposal we're making is not whether it's perfect, but how it fares compared to the highly imperfect reality and very expensive reality that we all find ourselves in. And then one final last word, which was a quote from an article shortly after the Affordable Care Act was being implemented, and some of its distortionary consequences were being realized by people who thought it was a grand idea as long as somebody else was footing the bill. Of course, I want people to have health care. I just didn't realize I would be the one who was going to pay for it personally. If we want other people to have health care, some of it we will have to pay for personally, and that's just the reality of the situation that we're in, and the sooner we face up to that and decide how much we want to spend on that versus all the other good things, the better off I think we're going to be. So with that, let me stop, and I think I'm well within my time, so I reserve my time for rebuttal. Thank you very much.
You may use such time as you may consume, as they say on the floor.
Thank
you, David. I'm going to stay seated in introducing our next speaker. By the way, I was surprised you missed the chance to at least recycle the Yogi's Aflac commercial, which is you can give them cash, which is just as good as money. But in any case, Peter Nelson is our first discussant. He's currently a senior policy fellow at the Center of the American Experiment. Peter does a lot of work, not only on state policy, but obviously interacts with national health policy as well. He has a broad background in one of the areas which we'd want to explore here, which is, okay, what can you let the states do? And what do they try to do? What can't they do? Or what might be possible on that front? He has additional background as being in the previous administration, senior advisor to the administrator of CMS, worked with all sorts of proposals, and some that got through for insurance regulation changes, as well as state innovation waivers, where the concepts are more innovative than the execution, but potentially there might be some other opportunities there. Peter's spoken here several times before, first on how to change around employer-sponsored insurance. Then we did the individual market. So now you're taking on the easy one on Medicaid. Peter, you can go to the podium if you wish. He has a few slides. And Peter Nelson, ladies and gentlemen.
Well, thank you so much.
And he's another lawyer, once again.
Yes, I'm another lawyer, but I don't really practice law. I just think about it. So I was in the previous administration, and Uber apparently still thinks I'm in the previous administration. When I got out of the hotel to get my Uber today, it showed 200 Independence Avenue as the next place I needed to go automatically, and that's the Humphrey Building, where HHS is headquartered.
Matter of political opinion, isn't it?
So what's that?
Where you need to go next.
So here I am, though, at the American Enterprise Institute. And so I want to start by confessing that I have a lot of alignment with what David just said. In fact, I've been talking about the benefits of defined contribution over defined benefits for years. In fact, pretty much since I started. And when you go back to, I believe this is the first major report I ever wrote on employer-based insurance and individual market insurance, I basically explained in the report. And by the way, the report was titled, "A Primer on How Employment-Based Health Benefits and the Tax Code Distort the Healthcare Market." And the quote I just want to leave with at the beginning here is, "Employers generally offer only one health plan, which limits value-enhancing competition among health plans and undermines a health plan's ability to know what employees, the actual consumers of their product, want and need in a health plan." And since I wrote that, I've basically been pursuing policies that give individuals more control over their dollars, give them more control over the health plans that they choose. I just think that's a better way to organize this market, creates better incentives that drive more competition within the health insurance space and within the provider space. So I also have a lot of alignment with David's view on the need for a deal. So I happen to have some experience with what it might take to strike a deal because I was in the previous administration. And I started there in late 2017, and as Tom mentioned, I worked at CMS for the administrator, Seema Verma. And at the time, several conservative states were under tremendous pressure to expand Medicaid. Dave, he outlined all these states that came after 2018 that expanded Medicaid, and those were all states that had a lot of pressure to expand Medicaid. And one of the reasons why they had a lot of pressure is because a lot of the states had initiative referendum, where the state knew that they were actually going to expand Medicaid. And so states wanted to have some control of those. State lawmakers in particular wanted to have some control about how they expanded Medicaid, because Medicaid, of course, has a huge impact on state budgets. They didn't just want to leave it to the ballot box. And in particular, one state had an issue because they knew the ballot was coming. And so we wanted to come up with some sort of idea that was some alternative to just straight up expanding Medicaid. And so that stirred up quite a debate. And in July of 2018, this is the headline in the New York Times that I woke up to one day. "Trump spurns Medicaid proposal after furious White House debate." Now, I wasn't in the room during that debate, so I can't confirm or deny how furious that debate was. However, I can confirm that it's my view that usually these headlines exaggerate a little bit to get some readers. And because my experience in the Trump administration was usually a very civil and productive debates, but we certainly had debates, as everyone should. But at CMS, when it comes to making a deal, we wanted to do something related, basically allowing partial expansion. So instead of expanding Medicaid up to 138% of the federal poverty line, we would just go up to 100% and include certain other provisions that were more conservative and that encouraged people to get back to work. And that was our view. But the problem with that view is that it still leaves this 90% match that creates terrible incentives within the system that still keep costs kind of going out of control. And so basically the White House was very concerned about that, and the truth is it didn't do that much in that regard, and so we just didn't really get to a deal. And ultimately at the time there was no good policy solution, and it was really a damned if you do, damned if you don't position. And since 2018, most of the initiative referendum states that could expand Medicaid, as David's slide shows, have expanded. And so, therefore, we've really had very few conversations about Medicaid expansion recently, but that does not mean the issue is gone. We still have this broken system that expanded Medicaid in most states, and we still have coverage issues in states that haven't expanded Medicaid. And so with that track record, lack of coverage, and the constant drumbeat from hospitals, there are some conversations on expanding Medicaid that have recently been percolating in states like Georgia and Mississippi. Without a deal for these holdout states, they're ultimately going to expand Medicaid. And so we really do need to come up with a better approach. We do need to come up with a deal. So what if Medicaid expansion holdout states have another opportunity to make a deal? Will things be different? I think the answer is yes. Time was a big obstacle in getting to yes in 2018. Developing a meaningful alternative to Medicaid expansion needed more time. And so just consider 1332 waivers. These are waivers that are allowed under the Affordable Care Act to let states get out from under certain other provisions of the Affordable Care Act. Now, we published guidance, new guidance in the fall of 2018 that allowed far more flexibility on this. However, we knew in the fall of 2018 that we were still a little bit late to the game, in fact, a lot late to the game, because by the fall of 2018, legislative sessions at the state level had already been organized, agendas had been set, so the 2019 sessions were done, and all of a sudden it's 2020, and it's another election year. And so guess what? States are not going to take that on, because even if they did get something done, it would be still into the next administration as far as when they were able to finalize their approaches and get things approved. And the Medicaid situation was under the same sort of timeline. So, but looking forward, assuming we have a change in administration next year, there is far more experience from the first time around that can allow the administration to hit the ground running to actually get a deal. So what should a deal look like? I can certainly see David Hyman's defined contribution plan fitting in with the 1332 waiver for people with incomes above 100% of FPL. And that would be coordinated with a Medicaid 1115 waiver, possibly. But what could that 1115 waiver look like? Could it be a defined contribution plan? Now, don't have nearly the experience in 1115 waivers as I do with 1332 waivers. However, I suspect a defined contribution approach would have some difficulty getting approved simply because it doesn't have the same automatic benefit structure. So I think you would have a challenge. But let's just assume right now that you could do it through 1115 waiver, or maybe Congress would actually step in and say it's okay. I still see some policy issues that would need to be addressed if we were to go down this road. The main problem with the defined contribution approach, the main issue, I shouldn't call it a problem really, it's just an issue you need to address, and that is the fact that the population of people below 100% of FPL are a very different population. They have higher health risks. They have a higher rate of chemical dependency. They have a higher rate of mental health issues. And this fact presents two problems. The first problem relates to the risk pool. If a defined contribution of the risk pool of the individual health insurance market, because defined contribution might be used and probably would be used to buy individual coverage, and this higher risk population moves into the individual market, it will increase premiums because it will increase the risk profile of the individual market. The second issue just relates to the fact that these people with higher cost conditions are also likely to have less ability to manage their care. And that the lower ability to manage care will basically result in worse care for them, and it also could actually increase costs to the state depending on how things move forward if they end up going to the emergency room more and just delaying their care more. So let's take a little bit deeper dive into the impact on the risk pool. When you look at the risk pool, we actually have some examples across the country to think about, because there were Medicaid expansion efforts that use premium support in the individual market to provide coverage to this expansion population. Both New Hampshire and Arkansas have done this. And the New Hampshire approach, however, didn't last too long. They started in 2016 and ended in 2018. And when they ended in 2018, Governor Sununu sent a letter to HHS Secretary Alex Azar and explained why they stopped. And he basically said that by stopping it, the premium subsidy program will bring greater stability to the individual marketplace, which experienced, quote, upward rate pressure due to the inclusion of those receiving Medicaid services. Now, this next slide gives you a picture on what was going on in New Hampshire. So the line that you're looking at is just enrollment. That enrollment hopped up in 2016. That's because there's a huge number of new Medicaid enrollees that jumped into the market. And in 2019, it dropped when the program ended. You can see the bars. The bars are the rankings, the ranking of the state in terms of the individual plan liability risk score for the state. And that's basically a measure of the risk experience within the market. And you can see on the front end, they were in the top 10 healthiest states in the country. All of a sudden, by 2018, they were in the bottom 10 least healthy states in the country. That's a clear problem for the individual market. And the people who were paying the higher premiums were unsubsidized people. This next slide is basically it's a similar way to say the same story, but it uses a little different measure, and that is the hierarchical condition categories. That is the health policy experts' way to define a chronic condition. And it shows that when you look at the New Hampshire market, and I also included the Arkansas market because they also were putting the Medicaid population into the individual market, there is a much higher percent of people with one or more chronic conditions in those markets when you look at 2018 in both markets. And you still have a little higher percentage in New Hampshire and for the measure of 2+ conditions and 3+ conditions. Then you move to 2019 when New Hampshire basically drops Medicaid people from their market, and they're now all of a sudden below the national average. The national average is that dotted line. So there's a very clear impact when you start introducing this population to the individual market. And it's not a good impact. And so when you're looking at what we think you need to do to create a defined contribution approach, you definitely need to account for that with some mechanism. And I want to conclude with just a discussion on people in this that are these higher risk people. I was introduced to this issue back in 2009 when Governor Tim Pawlenty in Minnesota line item vetoed general assistance medical care. This was a program for low-income people in this expansion population before expansion happened. And he line item vetoed it to not to get rid of it, but to reform it. And what happened is that we basically convened the state of Minnesota to develop, okay, well, how can we do this better? Before, we were just a financing mechanism for hospitals that really wasn't serving the patients very well. And what we ended up with was a much better approach that actually created some incentives for the local hospitals in the Twin Cities to take a much more managed approach to the patient and identifying patient needs on the front end versus waiting for people to go into the emergency department. And that worked immediately, but then Medicaid expansion happened. Now, Hennepin Health, which is on the slide today, is basically the evolution of that under Medicaid expansion. This is a HMO, but what they do is they're very much coordinated with federally qualified health centers, the level 1 trauma hospital, and also just the county social services department. And so they're very coordinated. They've had, I think, a lot of success in what they've been doing. And I think there is a small portion of people who really need something like this within this approach. But that is not the entire population of people. What New Hampshire and Arkansas found was that when people were moved into individual market coverage, they had much better outcomes. When you're paying private pay rates for coverage, you actually get to see a specialist way quicker than if you're in Medicaid. And so the evaluation reports for those programs were actually very good. The trouble is that in New Hampshire, it really had a negative impact on the risk pool for the individual market. So they had to move on. So those are the two things I think you need to pay close attention to with this defined contribution approach. And with that, I will leave it to the next speaker.
Thank you, Peter. Our next discussant will be Andy Schneider, who's a research professor of the practice at Georgetown University's McCourt School of Public Policy. Andy has extensive experience across the healthcare sector, focusing on Medicaid, congressional staffer, executive branch, outside scholar, working on it. You think of Henry Waxman has hands all over the building of the Medicaid program. Andy's calluses are in between the lines on a lot of that legislation, is working with him. More recently, he's working on Medicaid managed care organizations for children, some research on that, and another lawyer to talk about this from a little different perspective, Andy Schneider.
Good morning. Thank you, Tom. Thank you for inviting me. I'm going to be brief. I want to just spend a minute and explain to you that the Center for Children and Families, where I work, is a nonpartisan policy and research center at the McCourt School of Public Policy at Georgetown University. And
Just click one over for your slide.
I'm sorry.
Right here.
Yeah.
That should be on the remote.
On the remote.
Just the green to the right. Just the
Okay.
top one.
Yep.
Just click it. No, the green. Green.
Well, you're talking to somebody who's colorblind.
It's
So-
it's a traffic test.
It is a traffic test.
I'll
Yeah,
get
you do
I'll
it.
get it. There we go. All the information everybody needs.
Oh, that's good. Okay. So, so at the McCourt School of Public, it's a research center there, and our mission is basically to make sure that children and families have affordable, high-quality health care coverage. And that means mostly making sure that if low-income families are eligible for Medicaid or CHIP, the Child Health Insurance Program, that they're enrolled and that the programs work. So you can see where this is going. I'm sort of a defined benefit guy, not a defined contribution guy. So we have an issue here. What I do like about the paper, and I'm only going to talk to the Medicaid expansion issue, is that it recognizes there is a problem, that we have these 10 holdout states. They've been holding out for a while, and they're leaving a lot of people dangling in the wind, uninsured. So we do need to solve for that, and I appreciate the efforts of the authors of the paper and the commentator to figure out ways to improve the situation in those states. I don't think the proposed solution is going to work. I'll use Tom's metaphor. I think we're going to end up with a zonk if we go down this road. But let's talk about that for a second. So first of all, the population here are low-income adults. And by low income, we're talking about under $21,000 a year in income. Okay. And many of them have far less, particularly in these 10 states where for parents with dependent children or caretaker relatives, the mean income level, eligibility levels for Medicaid now are below half of the poverty level. So under $7,500 for an individual. So we're talking about very poor people, and as Peter mentioned, there are higher rates of mental health problems, mental health conditions, and substance use disorder among this population. So, and of course, a lot of them, having been uninsured for a long time, have higher unmet needs for health care and are at higher risk for utilization. So I think I'd start with the table that you saw of the decline in the holdout states from 2015 to 2023. And we're moving down from 21 states to 10 remaining states. One of the drivers there, as was alluded to here, is the notion of a ballot initiative where people decide to go to the ballot and vote whether they want health care coverage or not. And it turns out that a number of the states, 7 in fact, that have gone into Medicaid expansion, Idaho, Maine, Missouri, Nebraska, Oklahoma, South Dakota, Utah. In all those states, when ballot initiatives were put before the voters, they voted for health care coverage of the defined benefit variety. And it's not entirely surprising that they would vote that way because the deal on the table is not a bad deal. If you're not into defined benefits, yes, it's not a great deal. But if you're a defined benefit person, the notion that the federal government will pay 90% on an open-ended basis of the cost of coverage for your expansion population, that you have flexibility in defining the benefit package, but you have to have a defined benefit package for the population, that if you take the deal now and you haven't expanded yet, you get an additional 5 percentage point increase in your federal matching rate for your entire population, other than expansion, for 2 years. It's a very good deal. It's a very good deal. And North Carolina is, a state where I think most people would agree that set of incentives made a difference. That's in place. There are, of course, constantly questions being raised about whether the 90% match is going away, whether the 5 percentage point bump is going away. Nothing has gone away. None of the states that have adopted expansion have rejected it. Nobody's walked away from it. And I know in the paper there is, I think, some reasonable concern about low tax states wanting to stay low tax. So you would think if you're a low tax state, you don't take this up, because even though the federal government is paying 90% of the cost, there's still some residual liability for you as a state policymaker. So, if you look at the 10 states with the lowest tax burden, which I have to thank the paper's authors for introducing me to this particular rating system, this is total tax burden. 6 of them, New Hampshire, Delaware, South Dakota, North Dakota, Oklahoma, and Nevada, are all expansion states. Some of them by ballot initiative, and some of them just came in right up front, like New Hampshire and Delaware. And neither of those states has walked away. They're still low tax states, very low tax. So you do have to ask the question, and I'm not an expert in state finance, how bad exactly is this deal for low tax states? Does it put them in a position to protect their low tax status and still reduce the number of uninsured in their state, protect their academic health centers, their safety net institutions, their federally qualified health centers, et cetera? It's just a question, just a question. As you can guess, I'm an incrementalist about this area generally. I do think it's worth taking a closer look at the proposal on the table. I had some questions about it, and then I'll stop. So there's a reference in the proposal to an overall cap on spending. So I didn't know how to read that, and I hope this comes out in the discussion, but if we're talking about a cap on federal contributions in the matching form to state spending on this population in these states, I think that would certainly raise concerns for some of us who like the current structure of the program, understanding that it can be improved. There's lots of things wrong with it, and it needs to be improved, but one step at a time, please. What is that overall cap on spending, and do the states who we're looking to market this proposal to understand that there would be an overall cap on federal spending for them? And if there is, what are the implications of that for the people enrolled? Because ultimately, we're talking about the risk of healthcare inflation. And the authors of the paper have a great deal of respect for the ability of the market to tame healthcare inflation as long as consumers can make their own choices. I don't know. I don't know about that. I'm just wondering, so somebody with sickle cell with an HSA, needs the 2.1 million or 3.2 million treatments that are now available. How does that work exactly? We could walk through a lot of different examples of high-cost services, treatments, life-saving or not. It's not clear to me that, at least for the national markets, that putting dollars into the hands of individuals in these 10 states, assuming the states take it up, is going to result in better prices from a lot of these institutions or providers or manufacturers. The other thing that's unclear, well, there are a number of additional things, and I've shared them with the authors, but the other thing that I'll leave you with is going back to the question of how do we get this proposal anywhere. Congress seems to me unlikely for reasons that you can understand right now. If a state is going to pursue this, it would be, and gets its questions answered about how this all works, it would be through the 1115 waiver process. And there we have a statutory standard, which is it likely is the demonstration likely to assist in promoting the objectives of the Medicaid program? And the Medicaid program, is a defined benefit program. It has been. And at least for the foreseeable future, it will be. So there is a serious question as to whether adopting a defined contribution model promotes the objectives of a defined benefit program, particularly given the risk of shifting the cost of healthcare inflation to the states, to the beneficiaries, and without any clear indication that it's going to make any change in pricing behavior for people with strong monopolistic positions. So I'm just going to leave it right there. There's lots to talk about, but again, I do appreciate interest in solving the problem of the what we'll call the coverage gap, or the remaining 2 million or so uninsured in the 10 holdout states. Thank you.
Thank you very much, Andy. I can go at warp speed here in the remainder point, feeling like Matt Damon is the last guest on my own show of Jimmy Kimmel, but whatever. We'll squeeze a little bit in before we go to Q&A. And this is kind of continuing on. David tried to lower some expectations. I can lower them even further. It's not that hard. Think of this as friendly stress testing for the way in which this is somewhat at war between what might be fortuitous, advantageous marketing and then the complications of administration. And they're frequently at war with each other in this area. Now, we could say that's the art of the health policy deal, but I don't mean the usual way of doing the art of the deal. We're going to kind of move beyond that, although there's some parallels with that, perhaps, in terms of how you can do that. A couple of years, let me go back there just a second. A few years ago, I was giving some great advice on how you want to sell this stuff, and David knows exactly what I'm talking about. Article about 20 years ago, where he gave the rules for hacks to succeed politically and why they need to educate wonks in terms of how to get political success. So we're going to use those standards and see how well this one will hold up on it. So
I'm hoist on my own petard.
Yeah, that is it. There's no battlefield shells involved on this one. That's correct. You met some of the standards, though, on that front. So these are the basics here, as to what kind of you have to go through. We'll go through these in a minute. Now, the anecdotes, not statistics, I think Overcharge handles that in spades. I mean, you've got stuff ripped from the headlines. They may not all connect up into a big, broad, coherent, but you've got plenty of examples of the man is really shafting you in the healthcare marketplace. So I think, and I think now the price is right on this one. I think it's been brought down from what it originally was as the opening issue. I tried to check on Amazon today, but even the retail markets are working well on that front in terms of having demand match supply. How about some slogans? You can use some help on this front, I think. I offered a few here. Some of them need to go back to the focus group, perhaps. You are talking to the customer, not to someone else. DB to DC, not QED. That doesn't kind of really flow off the tongue as well. Get more for less. That's a standard Republican ploy that does not usually market very well, even though it's supposed to. And tomorrow is your problem, not mine. All right. You need to find some allies. That's kind of the other component on this. Where could you find them? The lessons from other areas of the economy is you got to do a bypass, a workaround. Usually some type of new technology, a new face on the products. You're buying something different than before, and usually the old regulation can't catch up in that. This is the lesson most notably from telecommunications, information technology. Suddenly people wanted stuff that they didn't know they wanted before, and it was available to them. Maybe less so in transportation and energy, but that's the area we have the opportunity for deregulation. And the importance is to have more new winners than new losers you can count up on this front. And of course, unfortunately, you got to pay more in order to do this. So it's always more front-load gain, promises of back-end savings and back-end pain, but they never necessarily arrive. But that's the marketing deal. So also, David emphasized in the previous work, you got to have the right enemies. You got to have some allies, but it's also important to have some civil enemies. Now, there's this condition that I've noticed in government. It's called faceless bureaucrats. I don't know if it's a birth defect or acquired on the job. It's very painful, I understand, and they don't have a treatment for it yet, but all the pharmaceutical workers companies are working on that. Maybe the cash-based cosmetic surgery would probably do that. Special interests, old standby, fraudulent providers, greed and envy. Now, greed and envy, they can be your enemies. They can also be your allies, though. It's a mix and match depending upon which side of it you're going for. Binding time consistent choices, though, are a real enemy to deal with, because our human nature is we like something today and we want to change it tomorrow. And particularly in the healthcare marketplace, the idea of being held to your past commitments is very difficult to do. Personal responsibility, deferred gratification, that's pretty uphill. Those are your enemies on this front if you're talking about kind of people being able to actually manage their own system. And of course, the man's keeping me down or the system's doing it as well. Now, David also emphasized you have to have very simple solutions. Of course, I usually caution on this front, the words of wisdom from H.L. Mencken: for every complex problem, there's an answer that is clear, simple, and wrong, which can happen on occasion in public policy. And that is that first-party consumers can solve all. Maybe they can solve some. We can argue about kind of the degree to which that occurs. The last rule of hackery is to never give up and never surrender. And of course, the offset to that is that David has recognized this. The problem is, who are the repeat players in this marketplace who know how to do it better? They're exactly the folks you're trying not to get around, and the usual problem of concentrated benefits. Now, I'm running quickly, but I can always go faster than that. So there are some problems in terms of the nitty-gritty, in terms of why not, and how. How is the big problem, but let's talk about kind of, why you would want to do this. You got to get published. That's number one. There are other ones after that, but let's move down from that. Desperation, no other ways out, getting in the way of higher objectives. You moved my cheese and I want it to be used for something else. Until that's the real cramping item in terms of why healthcare is spending when we want to use it for something else, you're going to have some difficulty. Again, identifiable winners that you can come up with, getting in the way of higher objectives. A temporary suspension of disbelief will work pretty well, just throwing out the rascals or finding. We like newly appealing beneficiaries. That's how we've done our incremental expansions. If you can dress up the folks you're going to aid and make them particularly appealing and charming, you're going to get that going forward. So why not? It's always in health policy, disruption, inertia, the most powerful force in the universe, even more than compound interest. Works very well in health policy also. More visible losers are usually the case when you make any type of changes. And the windows of harmonic convergence for legislating or major policy undertakings are fairly rare because our system is biased to oppose, delay. It's just the way things are wired. They're not going to change on that front. And you kind of disturb some long-standing mental resting places we have. We like to think we gave it the office to take care of the poor. That's what Medicaid's for. We don't have to look under the hood. We felt like we did that well enough, and that kind of took care of it. So we're taking care of on that front. And there's a little bit of that distrust of letting beneficiaries have their own money to handle when we're not sure what'll be done. So anyway, we like to pretend that we've kind of taken care of the problem, even if we haven't. All right, how? These are the problems of unresolved matters that come home to linger. I'm going to cut through my usual pop culture slides. The problem of spontaneous combustion, which only happens with Spinal Tap drummers. We'll go another one, which is how you can be a millionaire and not pay taxes, as Steve Martin indicated. First, get $1 million. Second, tell the IRS, I forgot when they asked you to pay the taxes. Or you can open a health savings account, which would let you be a millionaire if you had $1 million, and you could not pay taxes on it, but that's another approach to it. But how really matters. The difference between what we think of as private versus market. You know, we already got Medicare Advantage. We've got Medicaid managed care. That's close enough for us in terms of private without thinking we have to kind of get this really vigorous marketplace. The problem has been pointed out before of dealing with averages and doling the money out as opposed to adjusting, matching the risk and rewards. Someone's going to come up short. If you really give it to those in need, everybody's going to say, why didn't I get mine? And the imperative is always feed the middle class first in healthcare. Trust is a big problem. Who do you trust to handle your healthcare? You don't trust the insurers. You don't trust the government. Actually, they do trust the employers now in latest polling. But the problem is also we don't trust ourselves. And until people will trust themselves to make more of these decisions, that's the problem of where the default put option is for who's going to manage this and handle it. The usual problems of infrastructure, connecting the dots, that's not kind of a long-standing issue. I'm going to, well, I got a couple more to go. What the heck? Some other issues in terms of how to start, which is what I emphasize. Andy kind of talked about that incrementally. You not only go incremental, you want to start small, but the problem is if you start real small, it's too small. So there's that sweet spot where it's large enough to have critical mass and you can't get rid of it. It's what happened with HSAs probably from the start, but not so small that it just goes away. And you can open doors, but you can't push people through them. That's where you run into some complications. The transitions, that opening slide David had in terms of the transitions with Social Security and Medicare, it's also true of almost any major health policy change. The early going, it's great until the transition hits you, sudden grounding on the floor. And the real key is if you get a conflict between other goods versus subsidized medicine, when the day comes where we say we want something else as opposed to the next increment of medicine, then we'll be there. All right, we've got, I'm going to give David a few minutes to rebut the entire panel. I think that's the easiest way to do it, and then we'll take some questions from the audience.
I'll stay here.
Either way.
Yeah. So first I want to thank Tom, Peter, and Andy for their helpful comments, and Tom for going first and last with 2 bites at the apple, and reminding me one of the perils of writing things is sometimes people find your earlier papers and then say, well, how do you square what you say here with what you said before? The title of the paper that he's alluding to is actually Fixing the Distributive Injustices in Healthcare. I think it then said a guide for the perplexed or something like that. So
how to get the have-nots to come out ahead.
Getting the haves to come out behind actually was, I think, the other part of the title. So these are issues that I've been puzzling about in various ways for a good long while. That was actually a response to a paper by Clark Havikhurst and Barack Richmond, who's now here at GW, for those of you who want to learn more about that. For Peter's comments, I take your points about both the promise and the peril of doing this sort of thing. I'm not sure, because we're not calling for either a premium support or an dumping sounds pejorative, adding people to the individual market, that the lessons from that carry over quite so directly to this. The proposal here is to give people money and let them spend it rather than giving them insurance. And the political economy of giving them insurance, partly I think there's good research indicating Medicaid beneficiaries don't value the coverage they receive it anywhere near 100 cents on the dollar. It's a lot closer to 50 or 40 cents on the dollar. And that creates obvious possibilities for making people better off by giving them something they value, money, rather than something they don't at full value, i.e. Medicaid. Andy, started off by saying I'm a defined benefit guy, so my prospects for persuading him were low to begin with, right? I'd sell short that possibility, and it's quite clear he doesn't think it'll work, and that's fine. The laboratories of democracy idea is that individual states get to experiment with these things. And that's true both of the states that opted into the current program and the states that opted out of the expansion. But what we're trying to do is meet them on their own terms rather than lecture them, this is a good deal and you should take it. We're trying to identify the factors that we think are important. Now, we don't know for sure what they will think is important, but they're, I don't think, going to go for the current deal, which is why we're trying to come up with ways of offering them a different deal. And if we can get 4 or 5 of them to sign on, we'll have cut in half the number of states. And if they're the big states, we'll punch well above our weight. So I don't view that. I don't take the view that, gee, we used to be at 20 and now we're at 10 and everything's just the trend will continue indefinitely. I think the holdout states are holding out because there's something about them that makes them not think this is a good deal. And it's not simply spite. There might well be spite, but it's politics, it's finances, it's I didn't know I was going to be the one to pay for other people's health care that may vary among states as to how much that's an impediment to moving forward. I certainly agree that these are, low-income adults that we're talking about. They don't currently fare very well in those 10 states, and I'm trying to come up with a way to actually improve their lot. This is not a let's stick it to the poor proposal. As for 1332 versus 1115 waivers, and whether the courts will accept that or not, I don't know. I think we'll see. I think the goal of Medicaid was to provide access to health care for poor people. I don't think it was to run a defined benefit program. I think that's a means rather than an end. And I've only taught administrative law once. It was a very unpleasant experience for my students. Anytime you teach something for the first time, I mentioned the trauma episode earlier. It actually happened 3 weeks before the end of the semester. One of my students sent me an email. It said, Professor Hyman, I know you hate Chevron, but this seems a tad excessive as a way of getting out of teaching it, because I didn't have to teach the last 3 weeks of the semester, which was Chevron. But nonetheless, I think we'll see. I think we don't know. We won't know until we try it. That's true of all sorts of things. But I think the imperfections of our current system, particularly for Medicaid beneficiaries who, even in the states where they have expanded coverage, have an insurance card that basically only works at hospital emergency departments and inpatient. It didn't really give them access to the general healthcare system, which after all was a big part of the goal of the Great Society programs, was to open the doors to the healthcare system for people. And I could go on, but I won't. So thank you very much to all of the commentators, and I look forward to comments from the audience. And thank you for coming to hear about Medicare and Medicaid and defined contribution approaches.
David suffered for his art. Now it's your turn. Jack, we have some questions from the audience. If someone, I see you right over there, please identify yourself. I know you've had an hour to prepare your op-ed. I assume it's already been published, so just the question will suffice, please.
Thank you. I'm Gerald Chandler. Basically, I have a 2-part question about Medicaid expansion. The first part is with the existing system, compare the existing system of what Medicaid recipients get to the health care they could get. How much health care are they getting compared to what they should get? The second part of the question is, at the defined level right now, is that a good level? Should it be higher? How do you decide what level that is?
So on the first question, there have been multiple studies about access of Medicaid beneficiaries. I think we do very well with pregnant moms. We do okay, but not great with kids. I think if you need a specialist, you're facing some challenges. We sort of heard discussion of that already. And you know, we can go through populations and diseases, but certainly if you offered people the choice between being covered by Medicare and Medicaid, it would be irrational to pick Medicaid for regular health care. Obviously, nursing homes are not covered by Medicare, so that would be the one area where you might prefer Medicaid. In terms of what's the right amount, I don't know, and neither does anybody else, but I would use what we're spending now as a starting point and see what the state's willingness to fund these things are, and whether the federal government is willing to sort of continue its open-ended commitment when there are lots of other things and we've got deficit funding of half of the Medicare budget, leave aside Medicaid entirely. I think those are questions that involve not just sort of, you know, positive issues of fact, but also values. Whether I'm any good at the former, I know I'm no good at the latter.
Okay, another question brewing. Go ahead, Andy.
Just quickly on that. So we have a lot of disagreements here, but I don't think anybody is going to disagree, and I'll just say it, that if you're a low-income adult and you're not eligible for traditional Medicaid, and you're in an expansion state, you're better off. You might not be as well off as you or others might want, but you're better off than if you're uninsured. You're more likely to have access, and so that's point one, just as a general proposition. And point two, you'd have to look before you were making a categorical statement about this in Medicaid at each state, because the way states administer their programs and the way things work in the trenches, in the different state delivery systems, there's a huge variation. And you know, the story in Minnesota is different than the story in DC or the story in, pick another, California. Right? It's just, before you go and answer that question, you have to look at, so how are things going in any particular state for that population?
Let me just, well, sorry, Peter,
I'd
you
like
go
to
ahead.
follow up on that because that's absolutely correct. It's different by state. And it was mentioned, Andy mentioned previously about New Hampshire and Delaware doing better, and even though they're lower tax states. And they're doing better because they've got a lower poverty rate. That's a big reason why. And the poverty rate, I'd love to see a scatter plot of poverty rate versus the quality of the Medicaid program, the quality of access to the Medicaid program. Because I think the lower the poverty rate, the better your Medicaid program is going to be, because the state has to devote less resources to it because it's lower poverty. When you look at these holdout states, they're high poverty areas in many cases. And it's really hard for them to make this expansion decision because that will put enormous pressure on the rest of their Medicaid program because they have a lot more poor people than Minnesota, Delaware, and New Hampshire. And I think that's a big thing we always need to recognize. It's not racism in these states, it's resources.
Well, New York never has problems finding more poor people as long as there's Medicaid money to attach to it. But let's see if we have any further questions. And seeing none, I will expand.
Well, let me actually just follow up briefly. So when I started working in this field, one of the first things people said to me about Medicaid is, if you've seen one Medicaid program, you've seen one Medicaid program. And so there's obviously huge variation, and that's going to complicate any response to how is the Medicaid program doing, places huge pressure on getting good data. But I think the other point about the research of Medicaid versus being uninsured is the randomized study that was done in Oregon gives us, I think it's fair to say, materially different results than the observational studies that have been done. And Happy to talk at more length about that, but I think it's quite clear that Medicaid reduces financial distress because it stops you worrying about the medical bills associated with going to see the healthcare system. But the evidence on positive health effects has been much more limited. The positive results in the first year, much less impressive in the second year, and then we didn't follow it, unfortunately, long enough to see whether there are mortality effects. So, I think the observational studies are much more positive, huge beneficial impacts. But, I do causal inference stuff. You should trust randomized studies more than observational studies.
Part of the problem in our healthcare politics is we tend to reward people or pay them for trying, not for necessarily succeeding. So as long as you throw some services at it, well, we did our best, and the outcomes are a different matter. They had one further question waiting to go before we wrap up. Thank you. Please introduce yourself.
I'm Tricia McDermott. I just wanted one suggestion. You might, instead of HSAs have some features you might not want. HRA might be a better. But your slides about like the assumption that people will end up that people generally do a good job of evaluating cost and quality and making good decisions, and that they would in this context and thereby lower costs and increase care. I have to wonder whether you really believe that. And then the other is what happens if like somebody who has a really serious medical condition has spent all their money?
On the former, rational choice model is people make decisions that maximize their own utility. I'm sorry?
That's what economists say.
Well, if you look at behavior in the real world, you see that, except to the extent there are a variety of impediments to doing it. And that's an invitation for us to address those impediments rather than throw up our hands and assume that there's some all-knowing person somewhere who can sort it out for us. In fairness, I've done work on online evaluations of doctors, and it's pretty chilling. Because I took the absolute worst doctors in 2 states, paired them with matched controls who had completely clean records, and patients weren't doing a particularly good job at telling the difference, at least in their online reviews. That's going to be a problem, right? But we do seem to have sorted it out in all sorts of complicated markets elsewhere. And when there are problems, we take steps to address it rather than running the entire world on a defined benefit model with all of the pathologies. Andy didn't like that word, but I think it's an apt description. I started in medicine, an apt description of certain aspects of our healthcare financing and delivery system. In terms of how do we deal with the unfortunate cases, well, I only have 2 minutes, right? Or not even that.
Sweep them under the rug.
No, that would be Tom's approach to this problem. My approach is to figure out which one of those we think we want to fix and are willing to pay to fix.
Priorities.
I think we set priorities. We also, because this is a multi-year thing, can recoup in second, third, and nth years money that was not available in the first year. And the paper has some ideas about how to handle that particular problem. This is not a let them eat cake. This is not a let them starve proposal. This is an attempt to try and move from where we are to somewhere that has features that will be better.
That's fine. We're going to wrap up in a couple of minutes. I mean, David's alluding to the problem of catastrophes, catastrophic insurance, and then somewhere, somehow, the money does run out. And the question is where the donut hole is going to be hidden or made more transparent, but you can't pay for everything everywhere all the time, and who gets to manage that along the way. I said at the start of today's program, this is an ambitious, honest effort to try to work through issues. They don't have all the answers because it's hard to do this type of stuff. But there's always a possibility that one gleaming thought might come through and turn out. And I said, before when we were starting our preview, I've seen pigs fly at least once. So there's always a possibility it'll do it again. And that might be David Hyman's proposal. You never know. So thank you all for coming today, and please thank our speakers.
Thanks for coming. Really appreciate it.